This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, this is an elderly patient and we have a complex scenario. The patient has a very hypermature morgagnian cataract and looks like there's a lot of liquefied cortex and we don't know about the zonular health. At the same time, the nucleus also is very dense. It looks like a brown cataract hidden under this pocket of liquefied cortex. The another issue is the patient has a pre-existing 3.5 diopters of against the real astigmatism. So multiple challenges to deal with. So my initial thought process is that I'm going to try a phacoemulsification and put in a toric lens. We got the toric lens ready. And in the event of an intraoperative difficulty or a complication, maybe I would just convert it to scleral tunnel manual SICS surgery. That thought, I have planned that my incision would be a scleral tunnel incision, which could come in handy in the situation of any intraoperative crisis. So I mark the axis, I begin the surgery by making these two paracentesis incisions. Staining the capsule is critical. I want to get a good stain. I prefer to stain it under the air bubble. The dye is washed off with PSS and now I'm going to put in a dispersive OVD to coat the endothelium and also to pressurize the antechamber. And now is the time to perform the main phaco incision. I'm sitting temporally and I'm making a scleral groove 1 millimeter posterior to the limbus, and this is transconjunctival. And then using a 2.8 millimeter keratome, I'm going to create a sclerocorneal tunnel first. And approximately about 2 millimeter into the cornea, I'm going to enter. And so we have a sclerocorneal tunnel incision, and I'm hoping that's going to serve me well. And I'm just praying in my head that the things would go on very easily and I don't need to actually enlarge this incision. So time to perform the rhexis. The anterior capsule is punctured with the bent 26G needle, and as expected we can see that the liquefied cortex is starting to pour out into the antechamber. So the visualization is slightly muddled. I go in and do a gentle irrigation just to flush out this liquefied cortex. So we need to be very careful not to over pressurize the bag here. And watch where I place my OVD. OVD is placed in the peripheral part of the antechamber, not in the center. So with the capsule, with the antechamber formed well, time to continue with the rhexis. So I'm going to prefer a forceps to do the remaining part of the rhexis. It gives me better control and it's easier to go and re-grasp the flap and complete the rhexis in situations where we are having liquefied cortex and a mobile nucleus beneath. Chamber is refilled with OVD and the rhexis is eventually completed. So I wanted to ensure that the rhexis is relatively big. It should be at least 5 millimeter because I don't want to put any stress on the rhexis margin during nucleus division maneuver, and I expect the nucleus division to be difficult looking at the density of the nucleus. So I'm reasonably happy that the rhexis is alright and not too small. And also the zonular health seemed to be okay. There is no evidence of any zonular laxity during the rhexis creation. So these are the two positive things which are motivating me to continue with phacoemulsification. So the challenge now is division of the nucleus because this is a hard nut and it is also mobile, so we don't get that stability to get a good vertical chop. So one option would be to go in with a horizontal chop, but in this case I decided to try the vertical chop. And the most important trick to get a good chop is always to ensure that the burring is very deep into the substance of the nucleus. To aid that, I'm going to create a small central pit, and I'm using continuous torsional energy to create a small central pit here, and I'm just hoping that the nucleus doesn't jump around a lot. So I'm creating a trench which is at least about 30 to 40% deep. So that would give me access to the core of the nucleus, which would ensure that I can get a good hold. So once I'm satisfied with the depth of the trench, now is the time to go ahead and divide the nucleus. So remember, there is no epinucleus or cortex, so there is no underlying cushion. So we need to divide the nucleus in the most stress-free manner, and to aid that, I think it is worthwhile to have a very sharp vertical chopper. In this case, I'm using the Dr. Chang vertical chopper in this case. It's a new one, so that it can pierce the nucleus quite easily. To get a successful chop, there are a couple of physical forces that need to work well. One is the grip. We need to have a solid grip here, and that's a challenge because the nucleus is mobile. So I'm hoping that by creating this deep trench, I'm really going to get a good hold by burying my tip into the core of the nucleus. So the tip is buried now into the substance of the nucleus, and I go in with the vertical chopper, which is a sharp tip, and it's about 1.25 or 1.5 millimeter in length, and it is placed just in front of the phaco tip. And as I'm trying to do the chopping maneuver, you can see that the nucleus is tilting. So I just stop the chop halfway, only half of the nucleus is cracked. I go in and re-bury the nucleus and then do the lateral separation maneuver. The nucleus is rotated, the tip is buried, and the second chop is being continued. So we need to expect that the nucleus is unlikely to divide in the first attempt itself. So multiple lateral separation maneuvers with the chopper being progressively placed at a deeper plane is critical. I think one thing which is going to be of great help is to be very patient. So don't expect the nucleus to give way in a single score. So you need to make multiple attempts of scoring. And let me pause the video here. So the maneuvers which you need to practice is the right hand has to hold the nucleus steady and pull it just a bit. And the left hand with the chopper has to go down vertically and then laterally. Remember that this is a very fragile bag. So in the eagerness to get a good crack, there's always a tendency to make both the hands go down. And by doing so, we'll be exerting a lot of pressure on the posterior capsule, and there is every likelihood that the PC can tear. So being very gentle with the bag is extremely crucial. So ensure that the weight of your chopping maneuvers are never transferred to the posterior capsule. Lift the right hand up. The nucleus should be touching the anterior capsule as the lateral separation maneuvers of the left hand are being done very, very gently. The chopping maneuver is literally being done in slow motion. So you can see that it takes 3 or 4 attempts for me to reach the posterior plate, and then eventually the crack happens. The primary requirement in such a case, apart from obviously the understanding of the concepts and anticipating the difficulties, patience would be a great virtue to have. So now we have got about 5 to 6 free fragments, and the difficult step is over. The quadrant removal is probably the easier part here. So before starting the quadrant removal, I would like to go in and replenish the OVD. The dispersive OVD goes in first to coat the endothelium, and underneath it I'm going to place HPMC. So this is what I call as the modified soft shell technique, and now is the time to emulsify these fragments. So each of the fragment is picked one by one and emulsified in the central safe zone. The first piece is eaten off, and now I go in and engage a second fragment, pull it out of the bag, and then at the level of the rhexis margin, the emulsification is being carried out. Time to refill the OVD, and the fragments are again realigned so that it's easily accessible. The final few fragments again are to be emulsified. The piece was attached slightly to the adjacent fragment. Nevertheless, it could be pulled out quite effortlessly, and then I'm using the energy very judiciously to ensure that there is no chatter or flutter, and they seem to be joined at the base. And I'm going to refill the chamber with OVD, and with the cannula itself I'm just trying to ensure that all the 3 fragments are separated from each other. So in a controlled manner, each of these fragments is eaten off slowly. I made a rule that after every fragment I'm going to refill the chamber with OVD. That is a surefire way of ensuring that the corneal endothelium is protected. The OVD is refilled, and the last couple of fragments are emulsified in a very controlled manner. So the moral of the story is prepare for the worst, and when your planning is excellent, you'll be surprised that most of the times you don't encounter any complication intraoperatively. Most often than not, the intraoperative complications happen when you're least expecting, and that is because the preparation was probably not the best. The final fragment is out, and just trying to irrigate the posterior capsule just to clean it off a little bit. Very little cortex is remaining. Whatever little cortex is there, it's just aspirated out, and now is the time to place the intraocular lens. So this is a toric IOL, and I've already marked the axis of placement now. The lens is gently unfolding into the bag. The IOL is gently maneuvered into the bag. Both the haptics are in place. Before aligning the lens into the intended axis, I just want to ensure that the OVD behind the lens is aspirated out and followed by the OVD in front of it. Time to close. All the side ports are hydrated, and that's it, the case is done. The moral of the story in this case was it's perfectly fine to do a sclerocorneal incision that would bail us out when we would want to convert from phaco to SIS in any emergency situation. Especially when you're dealing with such complex cataracts, it's worthwhile to take this additional precaution. Now, nucleus management is the toughest part of the management in this case. Usually my preference is an horizontal chop, but in this situation I thought, let me try the vertical chop with a very sharp tipped chopper. So there's few cases where we want the chopper to be fresh and sharp. So this is one such situation where we're dealing with a hard cataract and a morgagnian one, which has got a free floating nucleus. So these are the cases where our chopping technique and instrumentation have to be flawless. So the secret to get a vertical chop is to ensure that the phaco tip is buried deep enough, and the chopper also goes and scores, and the lateral separation maneuver is attempted only after reaching a certain depth. So that was it. Thank you for watching, and hope you found this helpful.